the neurovascular anatomy is what the topic given to me was ECIC anastomosis. I was told tandem with ICA getting closed. So I would keep that slide to the last where I question the definition of what we would call a tandem. Because if you're speaking to a large or predominant interventionist community, the word tandem means a block both below and above, let's say in common parlance, and a block that is removable by materials. But to me, every atherothrombotic stroke as a strokeologist is a tandem. Why? Because you've got an artery throwing a clot which goes into the brain. So starting with that statement, I tend to question the dogmas. We should be practical about stuff, and emerging enthusiasts in intervention should be also be shown what is pragmatically possible. Because we've got corporates, we've got the institutes. What happens there might not be replicable in the other place. Since I'm no longer an interventionist, and because it's an intervention-oriented session, I had to beg, borrow, and steal. And a couple of my friends helped. Satheesh is actually my senior colleague working with me, neurointerventionist. And Dr. Karthikeyan is actually my junior. He was my student, and he's now doing an awesome job in Salem. So a couple of their cases. But in those cases, often what gets missed is the role of cross-sectional imaging. And again, on any of the stage, when you are an idealist, when you push your ideology, I always tend to push my neuroimaging ideology into most of my sessions. And I would be thankful for the entire stroke team, which means it could be a neurologist, it could be a neurosurgeon, it could be a neuroradiologist, and ultimately we all belong to clinical neuroscience. Case details, 2 cases. Why? Because I also want to show what happens to these patients. I can discuss a lot of embryology, but it should have a practical component to it. And I won't reveal what happens to these cases. I'll leave that to the audience. So case 1, the prelude, it's like watching a movie. Let's assume you got a 77-year-old male. And these are real cases. Very recent cases. Again, thankfully, we got them in the last month. So they won't fit the bill of a tandem with an ICA closing, but somewhere related there. So slurred speech, not much of weakness. And you can see the NIHS is pretty low. Again, talk NIHS to the neurologist, you get into trouble. So I will leave that to you. So less than 5, low NIHS. But what I would like to say is the statement below that, a non-disabling stroke. So then the first question here is, we have time. We are not pushing the button here like a code. Everybody is, rushing around saying every minute counts. Please, here, I want to save some neurons. Not that kind of situation. So then we have to start investigating. What we're doing here is a kind of investigative journalism. What were the comorbidities? What did he have previously? Everything gives us clues. And in a rush to lyse or do a mechanical thrombectomy, these gets missed. So what is important in that? Every part would be there. He apparently was on DAPT. And that means he had a previous stroke. And that had a left-sided weakness. And now we don't have a side to the weakness. It's more facial. Unfortunately, they didn't tell me which side of the face was weak. I don't do clinical examination. I am currently working on the stroke admin point of view. So I just take it out of the discharge symbol. So face, speech, side not known, previous history of right circulatory symptoms apparently. On DAPT, he decided to stop it. Again, these are things that is Indian specific. We have our audiences who tend to be, they are the biggest advocates. One, we say evidence-based management does not work in India. You have to counsel the patients. They don't agree. Ultimately, they decide what they want. So he decided to stop. Coming with recurrent symptoms. MRI, again, as I told you, I tend to push on the images a lot. So diffusion is probably the first sequence. Everybody does it. What else? Apart from saying, yes, there are multiple dots. The thing that I would like to point out is the watershed involved. The moment you have watershed, then we thinking, okay, this could be a block somewhere supplying that area. This block could be MCA, could be ICA. It's come with low NIHS stroke. So what else? We would now start doing all these diffusion flare mismatch. I don't know how many of them are serious about lysing based on the mismatch. And this is right up my ballgame. I'm very confident in dealing with doubts here. How many of you are saying there is a mismatch? On how many of you saying there is no mismatch? Yeah, I need both sides here. Come on, I mean, there is two sides to the coin. Diffusion again. Seriously, you really want to say there is a mismatch in this region? Good, great. This is one of the things I have been advocating for the last 2 years. Mismatch can be partial. Mismatch can be strategic. Guidelines don't cover for it. Currently, diffusion flare mismatch does not even come into the AHA guidelines. Only NICE 2023 says for a wake-up stroke, if you're looking at a diffusion flare mismatch, and if it's deemed to be present, you can lyse without an upper time limit. You can go back to the NICE guidelines, it's there. Because the purpose of the talk is embryology, I can't talk more on stroke controversies. So, when I report this, I tell the people there is partial mismatch, which means it's an evolving stroke, is the term I use. Next thing would be the vessels. Whole ICA not visible. Again, people who use MR-based imaging systems should know that this is a flow-dependent time of flight image, no contrast, which means if you see a vessel, it's there. If you don't see a vessel, it can still be there. This is the basic statement that we give to a TOF non-contrast MRI. I'm not going to go to the DSA specifically because I will keep it to the last. So this is one story. Anybody wants to venture out and say, what would you do for this patient? Who wants to go all in with all the instrumentation, DSAs, I'm going to do a thrombectomy, and then what else is the information you require? Probably the MCA is filling well. I don't see much of an asymmetry. Something going around in the bifurcation. Current imaging information that we have, which means I also need to look at what is happening here. There is probably a soft plaque there also. The story ends here. How many of you do perfusion in terms of non-contrast ASL perfusion? This we do without contrast. Fallacious. I just kept the slide, it's theory heavy. It's designed by Paget. It's more a homage to people who have done the hard work. She started as an illustrist. She worked with Walter Dandy. She went on to do probably the world's first research in neurovascular embryology. So this slide is more a homage to Paget, the first of its kind neuroembryologist ever. So as I told, how does the carotid system develop? It develops from our aortic arches. And among the arches, just remember, first, second, and third. 3 arches, the rest is not concerning with the carotids. More importantly, they start involuting. Anything down below the third arch for the dorsal aorta involutes. This portion gives rise to your first part of your ICA. The third arch artery gives rise to the primitive ICA, which means the CCA is somewhere here. What happens to this? This would become an offshoot or an off-sprouting. That system is called the ventral pharyngeal artery. The ECA is going to develop from that system. Second arch and the first arch will start involuting. The involuting parts will be shown in black. Just remember this thing. Communications can establish and persist between these arches. So we'll skip the theory slides. I'll just keep this one. So because it leads more in terms of our visual memory. The black ones are the ones that are regressive. Caudal to the dorsal third arch, complete regression. Ventral portion of the first and second arch, regression. Dorsal portion of the first arch, also regression. What leads or what remains out of the first arch is something called the mandibular trunk. What remains out of the second arch is called hyoid. And the interconnecting thing is the stapedial artery. Hyoid, mandibular, stapedial. Connections also develop between the developing ventral pharyngeal arch and this one. That will eventually give rise to your middle meningeal artery. Is that clear now? Again, I'll keep giving this visual memories again and again. I always believe the slides help me learn, not the theory. I keep reading the theory again and again. So I told you, first, second, third arch. ICA starts from the third arch. First and second becomes remnants. The second remnant, along with that interconnecting vessel, is now labeled the hyostapedial trunk. The first arch remnant is labeled mandibular trunk. Ventral pharyngeal offshoot gives rise to the future ECA branches. Star-marked connection that exists between the system and the primitive ICA-CCA junction eventually give rise to your middle meninges. What happens to the rest of the ICA? More cranially, there are three branches. We'll start from above to below. Ophthalmic, in that we have ventral or the more primitive, then the dorsal, and then the primitive maxillary artery. Three cranial offshoots of the dorsal aorta, the eventual IC. Ventral ophthalmic, dorsal ophthalmic, and the primitive maxillary. What happens to the posterior division is becoming your eventual PCOM. So the posterior division of your dorsal aorta, which future becomes ICA, becomes a precursor of your PCOM. The anterior division continues. Again, if I want to fail a DM candidate, I will ask embryology because I know he's only weakest there. And we are not taught this in a practical manner. The continuation of the anterior division is actually the ACA, which means the MCA, we are not talking about it right now. Phylogenetically, ACA forms first in lower animals, mammals and stuff. As the brain became bigger, then the telencephalon enlarged, the secondary vesicles started developing. It had to get more supply, and eventually a lot of branches had to go off from the ACA to the growing vesicles, which then became the MC, which means one, ACA is the embryological continuation of the IC, statement one. It's only when we do a vascular study, we say MCA is the continuation of the IC. It's not embryologically, it was never so. That is one thing. Second, PCA PCOM complex embryologically represent this. It eventually annexes the supply of the anterior choroid. So I've given 2 or 3 controversial statements here. If you've not been revising your embryology, but it's there, and you will understand when you see case examples why it's. One saying ACA is more phylogenetically older, which I think most of them would agree. MCA was never an embryological continuation of the ICA. 2, PCA PCOM complex exists in harmony with your choroidal system. So the theory again re-emphasizes the same. Again, a revision of this. So we can see the ventral pharyngeal, the developing ECA, hyostapedial, the mandibular, the connections becoming the middle meningeal, the third arch becoming the ICA, the continuation of the ICA, anterior division, posterior division, future PCOM. Anterior division is all about 2 A's, the ACA and the anterior choroid. No MCA being spoken about right now. And what happens simultaneously to the other side is the development of the longitudinal neurosystem. So it needs to be supported by the anterior circulation. And as it keeps fusing, the support starts regressing. So the support systems are divided caudocranially from the proatlantal, hypoglossal, aortic and the trigeminal. Aortic is a myth. People don't see aortic in their lives. Hypoglossal, I have still not seen. I keep putting the same slide from literature. Maybe I have not looked hard enough. Proatlantal, yes, we do get quite frequently. Trigeminal is probably the commonest that we see. But what is the importance of it? Any anastomosis between your anterior and posterior circulation at the level of your midbrain. Forget vascular thing. At the level of midbrain is your trigeminal. What is the embryological counterpart of the level of midbrain? We're still at the cavernous cipher. So if a vessel communicates between the anterior and posterior circulation at the level of your cavernous segment, we label it as a persistent trigeminal. So that in essence is a PTA, not your tau signs, not the spotters that they keep showing. So again, the statements PCOM is the remnant of the posterior division. Aortic and hypoglossus is very rigorous. We will talk about the trigeminal and fluid mantle with examples. Again, a graphical representation. Again, if you can now label these branches with, I forget the theories. So we had the dorsal aorta, eventual ICA, longitudinal neurosystem, eventual basilar, anterior division, which has been represented like this going back, just for understanding sake, posterior division. 3, I don't have the slide below, so I have to get it right. It will be embarrassing otherwise. I hope I get it right. So anterior division with the 2 A's. ACA, anterior coronal. The dotted line is where the MCA eventually forms. Then the PCOM. Then we have the collicular arteries and the posterior coronal. The 7 and 8 together are the ones that are there at the level of your mesencephaly. We finish with our anterior coronal, so it's easy to remember posterior coronal, followed by your collicular. Then we would have the cerebellar arteries, superior, inferior, which is in turn anterior inferior, posterior inferior. So I hope I've got that right. So I kept thinking whether I'll be able to get that right. Fine. So that is where we are at. And now we would say the statements again where I say middle cerebral artery. Now this also explains why a duplicated MCA is different from a accessory MCA. Accessory MCAs are nothing but 2 branches becoming persistent in adult life. We normally said only 1 branch should become persistent from the AC because it then becomes your proper MCA. If instead of 1, 2 or 3 become persistent, you will get accessory MCAs. A duplicated MCA, on the other hand, should actually see arising from your ICA by textbook definition. But at the end of the day, I always say, if ICA and ACA are a single embryonical vessel, why bother for the semantics? You're just having 2 MCAs or 3 MCAs or 4 MCAs, whether it origins from the ACA or the ICA. Ultimately, while doing the intervention, we just have to make sure if they have a duplicated or triplicated systems, that will be very misleading. You think you've recanalized the vessel and there could still be a blockage. And that's some of the things where maybe a direct to cath may not work and you still need your cross section. So again, a revision of the same. So why are we talking about this so much is now coming to the main part of the topic. What happens if one of the segment becomes regressive or is agenetic? Recurrent artery abuminous, again beyond the scope of this particular lecture. So before going into if there is agenesis, where does the support come from? Where does the anastomosis come from? If the ICA becomes agenetic, then it's going to be the ECA or the vertebral supporting it. But how do they exactly support it? For that, there are 3 or 4 developing systems. One is the hyostibial system, which I spoke about. Again, to recap, hyo is your second arch remnant. Stapedial is the continuation of the hyoid or the connection between your second and your first. What it does in the adult, it becomes your caroticotympanic trunk. What level we are at right now, I told you, third arch was the first portion of your IC. Then we had the second, which is your petrous portion of the IC. So right now, if there was a cervical agenesis, the hyostibial system has to take over. Where does it take over? Not at the initial petrous, it goes to the horizontal petrous through your caroticotympanic trunk. So for that, we need to understand what are the components of the hyostibial trunk. Hyoid artery, in general, again I only stop at the figure. This is your original stapedial artery or the hyostibial trunk. It passes through the stapes crura and is actually somewhere at the level of your petrous IC. And after that, it divides into your upper division and lower division. The upper division supplies the orbit. Along with the orbit, it supplies the dura of the anterior cranial fossa fluid. The lower division supplies the developing face. So terminologically, the upper division is called the supraorbital branch and the inferior division is called the maxillomandibular branch or something like that because it supplies lower down. What happens eventually, but we have the ECA getting formed, the ventral pharyngeal arch or the branches of the ECA which are getting developed. It has to now annex this supply. And when it annexes, what eventually happens is this regresses. Instead, the ECA along with this IMA, that is the internal maxillary artery, takes over the supply. And when it does so, the flow across the foramen spinosum will reverse. Because how does these two systems communicate with each other? I told you it was petrous ICA, which means it is intracranial. The ventral pharyngeal of the ECA system is extracranial. They can only communicate through the skull base foramen. So every foramina has embryological significance. I'll talk about each artery, the rotundum, the ovale, and the spinosum separately. But in this particular slide, the artery that annexes passes through your foramen spinosum. Eventually, that becomes your middle meningeal, which means somewhere during your embryological life, middle meningeal flow was actually top to down. It then became down to up when it started annexing from the EC. Is that okay? And if it doesn't, then you will have a persistent sequelae. Right? So you will have a branch that tweaks off at the level of petrous ICA, passes through your stapes crura. How much of it remains depends on how much the annexure failed to happen.
Can you explain this reversal across the middle meningeal?
If two systems are communicating with each other, this was the embryologically dominant system. This is the developing system. At that time, the flow is actually top down. This develops, annexes this. So the flow reverses across the floor. The middle meningeal is having components from both these systems. And that is one of the reasons why you got a lot of variations in the middle meningeal artery. I think that is one of those topics. I want to ask you whether that has all been covered. So it will be coming up. So let me go on to the rest. So again, illustrative example of the iostapedial system, the superior and the inferior division, and how it gets annexed by your ECA branches across the skull base foramen. Ophthalmic system, again very interesting because a lot of the intervention decisions is based on the level of the ophthalmic artery. They say any aneurysm distal to ophthalmic has to be treated. And you know, you will have that in conferences. I use ophthalmic artery as a takeoff. Somehow I just feel then we have a mismatch between embryology and practice. Because embryology clearly says ophthalmic is very, very variable knowledge. It traditionally actually phylogenetically starts from the ACA, top. And then even the ventral ophthalmic has to regress down to the carotid side. And only in human cadavers, 90% of the times, ophthalmic takeoff is intradural. Which means it is by no means a judgment that ophthalmic artery is your junction for deciding aneurysm treatment versus not.
So it should be a properly placed ophthalmic which gives you the right?
So much of variation.
It cannot be a blanket statement.
Blanket state. No, I have seen people telling it. I use ophthalmic as a landmark.
I think by that they mean a
normally placed. But even that normally placed, this is not abnormal. These are just embryological variants.
No, it's not abnormal.
90%.
It's not abnormal, but the
majority
location of the vessel is.
Majority. But now that we have the means of locating dural rings, and you have the DSA with the cone beam CTs, should we still rely on central dogma? I always feel we have to keep adapting to the needs of the occasion. That is one thing. Second, to take carotid cave aneurysms more seriously. When you have a transitional segment, and when you know that carotid cave aneurysms can have a neck that is intradural and a dome that is extradural, we should probably stop trying to dichotomize ophthalmic artery location as a means of these judgment. Maybe it's a multidisciplinary decision.
I agree.
T2 space, maybe look at combining MR angio T2 space and the DSA with your bony landmarks. So for people who are out there, I think they should not have that thing in their mind that ophthalmic artery, above that I will treat, it's all intradural, below ophthalmic, it's all extradural. I want to just take off that statement part of it. So I mean, I'll finish off that. So then what happens to the rest? The dorsal ophthalmic and the ventral ophthalmic. Dorsal ophthalmic, how do you recognize that this is a dorsal ophthalmic persistence? Is again through the foramen it traverses. Bones teaches a lot in embryology. If it was the ventral ophthalmic artery, it will pass through the optic canine. If it was the dorsal ophthalmic artery, it will be passing through your superior orbital fissure. So it's simple to differentiate that based on which is the foramen that traversed. The branches of the ILT, again, this is very important when you're dealing with EC-IC anastomosis. We can see this gray line completely supplied by the middle meningeal, which is your ECA system. And we have the red lines, which are all the ICA system. Across them, the anastomosis takes place across foramen. So we finish with the ophthalmic and we think, okay, fine, this patient has a properly placed ophthalmic, and we take that out of the equation, and there is no persistent dorsal ophthalmic. So then what happens? The infralateral trunk is the next system that we have to understand. The infralateral trunk will originate somewhere along the mid portion of the cavernous cycle. So it will be in the horizontal segment, the middle of it, and it will pass a bit laterally and then start going both anteriorly, posteriorly, and inferiorly. So if you have a branch, because I'm talking about very small branches and a branch of that branch, so it becomes imperative that you look at where it starts from, because that's all we might hope to see there. If you branch from your cavernous siphon from the mid portion of the horizontal segment, it is likely to be your infralateral trunk. And then how do you trace where it goes? It can give off anterior branches, posterior branches. Anteriorly, it will give off anteromedials and anterolateral. Anteromedial is very similar to what we discussed as the dorsal ophthalmic remnant. So it will traverse through your superior orbital fissure. Anterolateral will pass through your foramen rotundum, and it will anastomose with the artery of foramen rotundum on the other side. Then we have the posterior branches, one which is going through the foramen ovale, which will anastomose with your accessory meninge. You will have direct communication and branches that might anastomose across the foramen spinos. Posteriorly, what happens? It will anastomose with your ascending pharyngeal system. We have to keep on relying what happens on when we combine those images with this. So we are going anteriorly to posteriorly. We finish with the orbit, superior orbital fissure. Again, imagine the skull base foramen. Skull base foramen, the artery of the foramen rotundum is one of the biggest foramina there. And then you've got the ovales, you've got the spinos, the small foramens. Imagine branches going across all these foramen. Foramen lucidum is a misnomer. It is not a true foramen. It can also have recurrent branches there. And what are the source of these anastomotic channels? MMA, AMA, AP. So instead of again trying to maybe memorize all these things, understand these are possible anastomotic pathways. When you're doing a DAVF, when you're looking at even upper and middle meningeal embolizations, all these have to be at least excluded grossly, that you're not seeing the retinal blush. And when you're embolizing a DAVF, actually the channels open up much later. It is like the primary shunts disappear, the secondary shunts start developing. And you will see them coming back with recurrence because there's just too many to take care of. And to a question previously posed between onyx versus glue, and glue never used to take care of those. That's one of the reasons I feel as a resident DM, glue, because Guptaji used to talk a lot, but the failures of glue in DAVF was what led to the development of better embolic agents. And then the fact that these could percolate into these secondary shunts. Again, but I'm not an intervention expert, but just feel that is a huge advantage there. Starting to the next system, we finished with the iostupidial, we then did the ophthalmic, then we did the ILT, and now the meningo-hypophyseal system. Meningo-hypophyseal system, how do you identify? It's slightly behind your infralateral system, which means it would be somewhere near your proximal genu. So, in that case, you would see two kind of branches. One that actually does the similar vessels like your ILT. The other which goes entirely posteromedial. This is exclusive to the meningo-hypophyseal. You won't see an ILT branches going this far posteromedial. Imagine the carotid canal and the carotid siphon. So ILT starts much more anteriorly, orbit, lateral, inferior. Meningo-hypophyseal more towards the posterior genu, posterior, medial, maybe posterolateral a little bit. How do I then identify the branches? Hypophyseal trunks, easy, because it goes medially. So it gives rise to the pituitary blush. Then you've got the clival and the tentorial branches. How do I then differentiate that? In my mind, anatomically, tentorium has got two margins. You've got the basal margin, which is attached, and then the free margin. So you would, or it's the actual margin. So you have basal branches for your tentorial, as well as your marginal branches for the meningo-hypophyseal trunk. Now, why is it important? DAVFs here. And then you've heard of the term artery of Bernasconi and Casanare. So these are the tentorial branches of your MHT. Clival. Again, imagine clival going down, lateral, medial clival. Why is it important? Medial clival is going to anastomose with the opposite side. So you can get transcarotid anastomosis. Lateral clival will again go down and it's going to anastomose with your ascending pharynx, the EC anastomosis. I'm wantonly not putting that, I want you to visualize. Because the only way this reaches into the mind is visualization. And that's all I can remember. I can read the slides how many times, but I only remember this much. And the rest just goes like water for me. So then this was postulated by last juniors that we need an embryological classification. And I don't think people practice this that much. But the essence being, one segment gets blocked or occluded, the anastomotic pathways will reform the IC at the next level. So that is the concept beyond the embryological classification. At every step, if C1 and C2, which is your cervical and your proximal petrous, what is the remnant of this? Iosteprial trunk is the caroticotympanic artery. If this goes, this takes over. This is your artery of your Vidian's canal. It supplies to the IMA or the pterygovaginal branch. If this goes, MHT takes over. If this goes, ILT takes over. If this goes, ophthalmic takes over. It's beautiful if you actually start understanding how they work this out. Practically, I mean, is the names or the semantics that important? I don't think so. But it helps to understand why the reformation happens. So the theory is the same. There will be just one table that I wanted to show you for us to remember the names. So yeah, this one. At every step. So this is something that I made as a resident. I was fascinated by last juniors in embryology as a DM resident. So because I wanted to know, I didn't want to memorize or mug anything in a DM. Iosteprial trunk, the adult remnant is your CTA. How do you remember this? These are plexus that are formed around the middle ear, the tympanic plexus. The anastomotic level is somewhere around your horizontal petrous, which means if you have got reformation of your petrous ICA, it is only possible through your tympanic plexus. And the major vessels that are going to participate are going to be your ascending pharyngeals, you're going to be your IMAs, and eventually the posterior auricular with the ECA branches. Anything that supplies around the tympanic plexus will be the possible route of anastomosis towards reforming this. Similarly, the next segmental agenesis is parallel to the skull base. That is your mandibulovidian trunk, both from your ECS and the ICS. The distal IMA, the spinopalatine, those are the contributions which will form an horizontal conduit and again reform somewhere along the distal petrous or foramen lacerum portion. The next reformation will be through your MHT at cavernous, again infralateral to mid cavernous, finally through ophthalmic, which is what we commonly see. A new embryological segment was proposed. This is just an isolated case report. I don't know how much to take importance. It's an anecdotal data, but it's published. So somebody should not say, no, boss, you told me 6 segments, there's an additional segment. It is out there in the literature, but it doesn't change any of my understanding of it. Classifications, I think we should move from, again, practical importance. This is what I will hold on to. Neurosurgeons use this. And why they have to use this? They come from distal to proximal. So our terminologies cannot be distal to proximal. So Fisher is left to the neurosurgeons. I would say commonly used among radiology people is Bouthelius. I don't know the reasons for it. Endovascular people should probably merge together and use the NYU classification. This is a New York Langone classification that's purely endovascular. That's based on how do you treat the aneurysms at every segment. So ultimately it's going to be a problem of Greek and Latin. I should know what you speak. Everybody should speak the same language. Anatomy. So we finished with the embryology, the anatomy and the variants. Variants, as I told you, cervical, no branches. Usually doesn't give. But what are the variants possible? Every branch of ECA can arise from the ICA. Commonest is your ascending pharynx. Petrous, I already told you the two things that helps in reforming, caroticotympanic and your Vidians. How do you recognize? Remember, proximal petrous is similar to your cervical, no branches. These come up from your horizontal petrous. Caroticotympanic will move towards your middle ear, and the Vidians will move towards the skull base horizontally. This is how I used to remember. So you can also see it on the image where they say this this parallel branch across the skull base, somewhere from the petrous, anastomosing with your distal IMA, the sphenopalatines, the ascending pharynx. So this is your mandibulovidian trunk. Cavernous segment, we have to identify the MHTs, the ILT. Mecanose artery is supplying the capsule, the pituitary capsule. The importance of it, all tentorial meningiomas, DAVF, I think you can start looking out for it in your MRs. I think nowadays I've stopped even reporting that there is an MHT failure because it's that common. It's just that it was new to me when I was reading it. Every that sphenopetroclival meningioma is going to have an MHT branch for sure. Right? But for DAVFs, if you're able to identify a small branch and then you see a blush and then on your venogram it fills the superior petrosal vein, or if you're using an ASL showing the AV shunt, these are beautiful ways of actually increasing your risk. When do you want to increase your probability of an occult DAVF in a patient presenting with tinnitus, in a patient presenting with giddiness? Because this contributes a bulk of your patient spectrum. And people don't agree to a DSA. I always believe, unlike a cardiology, if you talk about brain DSA as an investigatory modality, people are worried. Sir, you're saying there's a 1% risk. I mean, do cardiologists really talk about risks when they're doing CAG? I don't think so. But we are so used to having to explain that 1% risk of stroke or even death or arterial things. But we don't do that. But I think the escalation can come from cross-section. In my report, I always say, I give it as suggested DSA correlation if I'm really confident there is something there. And then I take out the word DSA, I say suggested correlation, just like a routine radiologist, if I'm not confident. Important thing should not be mistaken for a tumor blush. This was the capsular mecanal artery and the PHIA from the meningoepiphyseal trunk. And many times what happens, there's overlap of a lot of branches, which we think is the MH. There is one more vessel that embryologically, very rarely you might see it. This is a vessel that traverses, it's called the intracellular carotid. One cavernous ICA to the other ICA. This is like anterior to anterior variant of your persistent trigeminal. A trigeminal goes at almost the same level, it goes back. You can have a vessel that goes horizontal. Again, the representation of it, if you're able to identify it, I mean, I again know headings below. So what do you think this would be? M. You can attempt, I mean, I don't know. I mean, I don't know the exact answer. I have to look at the. So it's going in front. So it's somewhere into the ophthalmic system, right? So it could be the DOA or something like that. We don't know for sure. But what are we sure about? What about A? Can anybody tell me what is A? It's a cavernous segment going laterally. So what could go there? It's the ILD. What could be B? Going posteriorly near the genu. It's the meningoepiphyseal trunk. I think at the end of my lecture or discussion or whatever, if you're able to say ILT, MHT for me, I'll be happy. Because it doesn't percolate beyond that. 10, 20 minutes, we are in the age of shorts and, Instagram reels. What would the dottal line represent? It goes to the basilar. So that's the PTA which we have not spoken about. This is the persistent trigeminal. So you can have a mental framework of the level from which the origins and how to identify. So these are examples of showing the same thing in specific locations. If you've got a giant ICA aneurysm, if the surgeon is going to lock off your ECAs, ICA is going to reform it. If you're going to lock off your ICA ligation for something else, the ECA is going to reform it. And that's why people have to do a trapping. Because it is not enough to do a parenteral occlusion if it's not fully occluding the inflow on both sides. We often forget an aneurysm has two inlets. What looks like the outlet will become another inlet once you block the other one. So you have to trap. So it's surgical or endovascular. So recapitulation of the same, again beautifully representing a microcatheter kind of injection from the ICA. So you can see the ILT branches, and then you can see the meningoepiphyseal branches. You can see the mandibulovidian trunk, and you can see the ascending pharynx. I think, and let's not go into all those things. Just that a microcatheter injection of the ICA, reforming your ECS, and how it's reforming cavernous. And in that mid cavernous, going down and laterally, then going posteriorly, ILT, MHT, mandibulovidian and the pterygovaginal trunk going along the skull base, anastomoting is your ascending pharynx. Finally, this, I think everybody knows the intradural ICAs, the dural rings, and the branches are associated with it. Couple of variations, pro-atlantal. Again, type 1 arises from the ECA, type 2 arises from the ICA. And the people have this way of removing or mugging up. I have no idea. I don't do it. I cannot do it. The embryological explanation for a pro-atlantal is the existence of cervical segmental arteries. You have a carotid, you have a vertebrovascular system. If there are cervical segmental arteries connecting both, they give rise to pro-atlantal. A first segmental, I'm not talking intersegmental, I'm talking segmental. First segmental will be above C1. The second segmental will be below C1. And that's why the second segmental is called the first intersegmental. Believe confusion, there's no more confusing than this. I read that I'm reading the slide for the first time, then I realized those bloody buggers have put that in the middle. I was wondering why segmental, intersegmental. The question was segmental, the second segmental becomes the first intersegmental. But the crux of the story is above C1, going through the foramen magnum, anastomosing with your intracranial vertebral becomes a type 1 pro-atlantal.
That is possible because you don't have a C0.
Could be. So I think sir was talking about somites and the spinal thing. So, but for me, I always tend to think, why is it so complex to do? It should not be so complex. If it's so complex, then how do I teach others? So then I realized, okay, fine, it's C1 as a landmark judgment. Above C1 and not going through the foramen transversorium, instead anastomosing within the foramen magnum with still the intracranial portion of the vertebral artery is a type 1 pro-atlantal. And the second one would obviously be just slightly below the level, but can able to pass through the foramen transversorium. Anastomosing with your extracranial vertebral artery is your type 2. But most of the times my examiner used to ask me, can you tell me whether it's from the ECA or IC? I just have an issue with that. It was never a decision because it clearly says a type 1 can arise from the IC or the EC. If I had known this, I would at least pass my exams with much easier. I would have confidently thought it can be anything. So those are the examples of the pro-atlantal. And then the hypoglossal, any vessel that goes to the hypoglossal canal. Let's leave it there. That's the simplest way to put it. PTAs, again, very complex definitions of Saltzman classification. People have this unique pleasure of trying to ask questions, just to emphasize that you don't know one bit more. Because you're telling all the answers right, so what else can they teach? So I was also wondering about this Saltzman. And embryologically, the definition was, if your persistent trigeminal is your sole source of supply to the end of basilar, which means no PCOMs. The trigeminal supplies your PCS, the trigeminal supplies your ACS. It then becomes a type 1. If you have additional support from your PCOMs, it's a type 2. And interestingly, then we have a type 3. If the PTA actually opens directly into a cerebellar artery. So if you're really keen on impressing somebody, I would say, okay, then tell me what is Saltzman type 3. So you have different types and the examples. Finally, the aberrant ones, and two important aberrant ones, the intratympanic IC, where they say there is no bony separation between your middle ear and the vessel. So you'll have a pulsatile mass, tinnitus often, and the reason for that is, it is basically a portion that is agenetic. We will still show you a cervical vessel, but it is getting predominantly reformed through your caroticotympanic and the tympanic plexus of vessels, which means it is around the middle ear portion. And because of that, the ICA seems to be more laterally placed and there is no bone between the carotid canal and your ear, the tympanic cavity. So that is one variant. The other variant is the kissing carotids, where you have a posterior pharyngeal course of your ICA that can also be congenital. Finally, we'll have the non-bifurcating carotid artery, ECA, ICA branches coming from one vessel. Again, two types, one straight vessel going, the other having a loop at C1 with a stump. Again, this is something that I'm able to understand embryologically. So I've been trying hard, but the examples are there. One straight vessel and the second where I have a loop with a stump. So this is supposed to be a non-bifurcating carotid artery. Finally, I have to leave a ode to the person who discovered this one. The last juniors and the family. So when Kaushik asked me, I told I'll give a ode to last juniors. This is just an ode to last juniors. I think the dedication that he had, and if you go into the site, the website, everything is there. And really, people who are really keen or passionate about vascular neurosciences, I think should probably read Last Juniors. If they're not able to read, because it's complex, 3 volumes. We tried having the sessions in DM where we told every Wednesday, let's have a half an hour Last Junior session. Even our consultants were not keen. because it's so complex, it's so difficult. And the website actually does justice in a more of a easy way to remember. It gives a lot of these line diagrams. And he was also a philosophist, because at the end of the day, it should all mean something. It should go towards improving outcomes for a patient. So that brings us to the story. So we finished with our embryology. I hope you've understood few things. First patient is entirely our patient, so I know the background details. He was NHS 2/3, minor stroke, no deficits. He had previous stroke, started DAPT, left that. No thrombolysis because the neurologist felt it's minor stroke, less than 4, not warranted. Stroke team counseling done. I really wanted them to do a DSA because I told them on MR, I cannot label this as a chronic occlusion. For me, this is an acute on chronic steno occlusion till you show me the lumen. Unless I see a luminography, I'm not going to change my diagnosis. Echo, cardiac, that kept happening. You have got 72 hours. I again feel that is one of the buttons to push. You can finish a gamut of stroke investigations in 72 hours. When you need it, you do it. Somehow the reluctance should not be on the patient side. Money is a big constraint in India. TCD was done. Now, I really wanted to know, I mean, he's a senior neurocritical care expert, so I don't ask him why the TCD was done. But when the juniors come to me and they said, "Sir, TCD paniyachu," I mean, TCD was done, and they told nothing picked up on TCD. You know, I look at the statement given on the summary. We had a right ICA system not seen, and it was suggestive of left MCA velocity significantly greater than the right MCA. So, which means the right is not hemodynamically stable on the TCD. But more importantly, I would be looking for hits here. The only thing I want categorically stated as a strokeologist, show me hits. I need to know whether this is a stump phenomenon, whether there is an acute this thing. If you're categorical saying no hits, I'm at least satisfied with stopping here. So, but anyway, we have a big system, so and we have to do, it's a corporate, so we have to do everything. Interestingly, the other thing that helps us is something called a pyeloemboli. I don't know how many of you actually report that. These are SWE dots that comes at the T4 pile vessels. Not all of them are type 1 hemorrhagic transmission. Every time there is a blooming foci in an infarct, the immediate response is to call it a type 1 hemorrhagic transmission. You have a susceptibility vessel side. You have a clot that blooms. Why can't an M4 clot bloom? Why can't it be within the gyrus? Why can't it be subpile? These are the questions I keep asking. So I always give it with a misnomer. I say it could be query a pyeloemboli because I'm worried about it. And I would say at the same time, I don't know whether it's an early hemorrhagic transmission. But the problem here is he was never on antiplatelet. Yes, cardioembolic can bleed, but would it be so early? Would it be so hyperacute without a background of DAPT? I'm not so sure. And because of that, anyway, they did the DSA. And you can see the stump here. And not much of intracranial filling. You can see a little bit of reflex into vertebral. But more interestingly, very bad looking IC. And going up to the carotids, the ophthalmic, and they told it's a chronic dissection. I leave the house open. What would you call this? Would you want to intervene? I have given the background story. Minor stroke, previous history of stroke, NHS route 3, multifocal infarcts, no thrombolysis, DSA the next day showing this.
So I would approach this from a clinician's point of view, right? So the acute question that you have raised is whether we should treat or not treat. With what? With lytics or with mechanics, and whether to do a DSA or not at the acute stage. So we would rather challenge this patient. So this is a classical low NIHSS with a large vessel occlusion. So you challenge the patient with a provocative test. So that would give us more clinical information based upon which we can take a decision.
So provocative
test would mean that we would make the patient stand up or give him hypotensive agents which diminishes the perfusion pressure in the brain. Say, let's say 10 to 20 millimeter of mercury would be good. So if the patient withstands that test, then at least for the immediate foreseeable future, you don't have a risk of your collateral failures happening very acutely. Second, this patient has had an embolic phenomena, no doubt. So that means that whatever has happened to the internal carotids cannot be too old. It has happened in the very recent
Acute
past.
on chronic
Okay.
or whatever you see, there's a
Sort of
component that is acute.
Yeah, acute on chronic maybe. And there has been it's not only a watershed infarct that has happened, there has been some embolus which has traveled into the parietal region. Okay. So possibly the neck is the culprit lesion where there was a acute lesion and that has gone into a total occlusion before sending him some showers. So based upon this MR findings that you have given, and if the patient still passes the provocative test, then best medical management would be the way forward. Other than that, if the symptoms recur and it happens, then you would be obliged to go in and do whatever you can to open him up. So that would be the clinical way of doing things.
Sriram, just from my end also, before what sir said.
I
know.
Do we have time? I mean, the second story is it.
Yeah, we have time. I am the organizer. So, so the one thing that is, if that's the same patient, that MRI also showed a left-sided infarct, right?
Yeah. So
that is also something. Yeah.
So I have not finished yet. So the DSA image is this, and I wanted to see the left carotid on the DSA as well. So intracranially in the left carotid has a kind of 40%, let's say, block on the opposite
side.
There
are thrombus there on that? No.
But these are the single shots. They told me just around 40-50% plaque stable. Nothing on the DSA that looks dangerous on the left side.
If anything, the right if it is completely occluded near total, I will still look at left whether it is still feeding the embolize to the right.
But I'm just worried. They told it stopped at the ophthalmic. I don't believe so. I believe there is an antegrade flow. And for me, if this vessel is diseased with still antegrade flow, I'm worried about the failure of antithrombotics. The question here is he on heparin? Is he going to be on dual antiplatelet? What is the duration of heparin you want to give? Because we do have anecdotal evidence for dissections, heparin. Even if you say there are unstable clots or thrombus sitting in the carotids. So if you're not going to do anything about it, because it's low NIHs.
Is this the middle segment?
This is the ICA, the right ICA. And they told predominantly it stops at the ophthalmic, but I feel there is some filling there.
This is the right ICA.
Right ICA.
So how was it opacified? Like you don't have
very delayed films, very delayed. So this is the first film,
So that
the stump.
So you mean that you have flow beyond the stump, right?
Yes.
Okay. So if that is the picture, then I would again fall back upon what is the status of the ECA flow. I would go to a ECA and try to find out at what segment the ophthalmic has been reconstituted. And if there is a backflow like this picture, it definitely pins down the lesion to the carotid segment in the cervical region. It's acute on chronic, and you open him up, no issues.
That was my doubt. I always, but the problem here is well preserved. You're talking about a patient who's walking, talking, and the moment we take him up for something in a corporate.
But still, it could be a secondary collateral failure. It could be a stump phenomena from where you can shower embolus. And then you come back to your previous question of how long. So at least for the next 3 days, put him on heparin and dual antiplatelets on board.
Both.
But be prepared, this patient can go down at any point of time. So at the middle of the night, if he, God forbid, deteriorates, you would be in a position to open him up.
Exactly. But heparin plus DAPT. So it's 3 drugs. BP high. The hemodynamic augmentation. Okay, so I think they did the heparin part. I don't know about specific BP augmentation, and we left it conservative. The final diagnosis, they actually call it chronic. I still don't believe. I keep arguing with my team. I don't think this is chronic. But most importantly, the final picture, he improved well. He was stable for 72 hours, and they sent him home. And we're talking about last week, so I don't have that long a follow-up. I believe he could still come back to us, or he could go to some other hospital because they believe we didn't treat them well. I mean, we had all these internal discussions that never percolates or trickles down to the patient attenders. And I'm still worried. I have not got follow-up on this. This was 21st, discharged on 24th. We are on 27th. So this is just a week old. So that is one thing. So, and the Holter is awaited because the left side, again, if the ICA is stable, can he have a superimposed occult AF? What is happening there? Can there be a clot that
there can be a significant plaque activation, the same inflammatory process going on both the sides. So it could be that also.
That also. So that was story 1. Story 2, again low NIHs, and he was advised thrombolysis. I don't know why, because I don't know the exact NIHs. This was given to me only on GCS. And they were not willing for thrombolysis. Again, stable, but only for 24 hours. They decided to go at 24 hours. And this is an outside hospital. This is just the images that was shown to me. And interestingly, after 48 hours, the script changed. He came back and is now having sudden loss of consciousness. GCS has now dropped. Just V1, E2. So we're just looking at 8 from what was a 15 within 48 hours. And is now got right-sided paucity and aphasia. We remember there was a right carotid occlusion documented. ICA was still filling on the MRI. No update on the common carotids, at least on the MR. The left system had infarcts and now has come with full-blown left hemispheric syndrome, so as to call it, maybe with a hemodynamic component to it. MRI, on the other hand, when it was repeated, is status same. The infarcts have not changed. What has changed was a lot of increased oxygen extraction in the veins. I mean, when we have hypoperfusion, we expect that instead of doing, this is an indirect penumbral surrogate. This is again one of the things that I keep talking about. You don't need to do a perfusion to get perfusion information. Perfusion information can be got from FLAR, it can be got from SWA. You have all those IV collaterals and then with an increased venous extraction on the SWA. So definitely a hemodynamic left hemispheric syndrome without progression of infarcts. No, we just have to compare. It's just qualitative with the opposite side. And as opposed to a thrombus, which I showed like a pile emboli, this will not increase in size. So when I differentiate that, I look at how black it is, what is the size of it as compared to the opposite. The pile is jet black, more black, but of the same size as the opposite side, is an increased oxygen extraction. More black, more increase in size is a thrombus sitting there. The first is more diffuse, this would be focal because this is more of a systemic problem, the venous circulation. And he felt it could be more clots from the AF that he had, throwing up more clots into the system. So it was already a very hemodynamically compromised system. Now it has deteriorated further and he took him up for MT. Now again, very interesting. I spoke about all the collaterals in the reformation. I never spoke about chronic carotid occlusions or the common carotid. And if you go back to literature, you will also see that there are 4 types of common carotid reocclusions, which will mean occlusions and reformation. All of them are based on, it forms either from the vertebral or from the contralateral side, eventually through the ECA. ECA is the conduit for the reformation of ICA in a common carotid occlusion. It's called a ICA steal, just like you have a subclavian steal. So that's important, you should know about it. And the types, most significantly, the least frequent is if the ECA is also occluded. Most of the times the ECA will be patent. So he has now come with that. Basilar circulation, good cross circulation, but through pile collaterals. But it's clinically not significant. Clinically it's not enough is what I would call it. So he's got pile collaterals, not but of PCOMs though. ACA is filling, MCA is also filling, and it was vertebral going on to ECA again, giving to the right ICA. Right CCA completely blocked, left ICA now blocked, right ICA going rise to MCA, giving rise to both MCAs. And there was a lot of clots in the system. So he did a Solumbra for the ICA. And if you see immediately on table, post ICA recanalization, because of the systemic imbalance, the chronic common carotid occlusion, the circulation pattern has actually reversed. It is now a left to right system. So which means the right was grossly insufficient to maintain the left. And the AF aggravated this. So very different finish to the story. He did develop some SH, he had some hemorrhagic transformation, but more importantly, he was managed conservatively. He didn't need any decompression or surgery. He was on tirofiban. I think many of them use it in this situation because a lot of unstable clots there. It was a PC3. I don't know why he opted for tirofiban. Maybe he thought there could be clots sticking around somewhere. And then seeing the hemorrhagic transformation, he stopped the tirofiban and went for optimal BP control. So any thoughts or words?
You say that there has been a hemorrhagic transformation, right? So a hemorrhagic transformation of an infarct.
Of an infarct, or maybe this is like a post-carotid stenosis reperfusion.
So you have to differentiate between the two because that grossly...
There was no new
deviates.
infarcts.
So if it was not an infarct on the MR, then how can you have a hemorrhagic transformation of that infarct?
So it's not an hemorrhagic transformation. We'll call it a reperfusion injury like we do in a carotid revascularization.
But the place would be very, very unlikely, right?
these are across the phone messages. I can ask him again how he thought this could be. What do you call as reperfusion? Because he called it pericerebral hypoperfusion.
It was very laterally placed and not a proper
You feeling
position.
it could be hemorrhagic transmission or infarct? No, would the management change?
No, not the management, but the
explanation.
The question of the secondary dipping. If he has an infarct, that perfectly explains the whole thing, of which you don't have, at least on this podium, imaging evidence.
The question here is, let's assume both the arms. Let's think this is a reperfusion injury. The strategy would be just like we do a post-carotid stenosis. We have to bring down the BP. We have to make sure. We cannot discontinue the DAPT.
See,
but he had a TAPT. He had a triple activity.
If you were like saying, so that a lot would depend upon how you place this lesion, of what kind. So as a clinician, I would think, without any imaging evidence, that this was all along an infarct.
And MRI was repeated. Pre-procedure, no infarcts, no new infarcts.
As a hardliner, I don't have that evidence right now. Right?
I'll ask him for that. I'll keep that in mind.
Because this is very laterally placed, very not fitting with a hemorrhagic transfer, not fitting with a reperfusion bleed.
SH?
And secondly, it has extended to the temporal region also, right?
Yes. This is that area you're talking about, laterally placed.
So you cannot go with your microcatheter and your microwire that far. Okay. So now if it's a reperfusion phenomena that you were speaking about, then you will have to do all the wrong things here. You will have to keep the BP down, you have to take off your...
How down? To C3, we are still looking at MAP of 90 to 100, SPP of 140 to 160.
Yeah, that's okay. But if it's a hemorrhagic transformation, you can still have your time and you can wait and watch.
But reperfusion, you're saying you have to be more aggressive.
Yeah. But this does not fit with the reperfusion pattern.
Okay.
So there comes the question of the first part, whether he had actually an infarct or not.
A progressive infarct.
Right.
Agreed. So anyway, so finally, again, this is last week's patient, so I'll ask him how they do, but I'll finish with this slide. At the end of the day, I think definition of tandem is what we give tandem as. We shouldn't be very dogmatic about tandems. I believe every atherothrombotic strokes are tandem. A clot below, a clot above. It's a question of what we do next. Clinico-radiological correlation, information on collaterals and perfusion goes a long way in prognostication. We need to look at which patients are likely to deteriorate versus who can remain stable. We need to finally agree upon the mechanism and the vascular hypothesis for not just acute treatment, but more importantly to prevent the next stroke. And special situations like what I showed, whether it's a chronic occlusion or a dissection, at the end of the day, I think we're just still learning. And it's a team consensus, and we still need more technical expertise and level 1 data on these. Thank you.
Thanks a lot, Sriram, for this. Any questions from the audience? I think quite a few were there. Anybody, any comments? I think
about the first scenario you spoke about, the triplicated MCAs or the duplicated MCAs. So you still can have a direct to angio approach. You have opened up your normal looking vessel, but still if you have a significant duplicated MCA, then you are bound to have a hypoperfusion and a vasculopenic picture. So that immediately gives you a clue that you have not opened all the vessels. That is equally true for a bifurcation and a trifurcation. You did not have to have a duplicated MC also. So you have opened up 2 branches. Still find that there is a quite deal of vasculopenia which is happening. So that is an angiographic clue of a missing vessel.
I agree. Not just for the embryology part, the direct to cath lab approach for me, at least in India, seemed to be from an admin point of view, not have enough positivity to 2 reasons. One, I believe we are still in the embryo stages of M2s and mid M2s and M3 occlusions, and they are difficult to recognize on the shoots that we take on the DSA, and even rotation might be required sometimes. But if you do a cross-sectional image, I just believe it picks up the occlusion level and guides us in preparing ourselves for the intervention. I mean, the time spent in counseling the patient is actually in Indian context more than enough sufficient to get a little bit of cross-sectional information.
Like as a counter to that, I would forgive me to say that at the midnight we don't have astute radiologists like you looking at the cross-sectional images, right? So it is left to us to decide and see whether we are leaving a M2 behind.
A good flat panel CT in the angio will solve both your problems, sir. So I think
Thank you.
I will stop this session here.